Welcome to a deep dive into a topic close to my heart, and I bet yours too, right? Pediatric emergency medicine. Now, before you think, wait, medical school,
Yeah.
relax. We're not becoming doctors overnight, but, you know,
Yeah.
you came with excerpts from Avoiding Common Errors in Pediatric Emergency Medicine, 2021 publication. So you're the kind of person who likes to be prepared, which I get.
And that's what this is all about. It's about empowering you, the parent, to spot those subtle signs, the things
That
that might not scream emergency but can make a real difference. Subtle, but important.
Exactly. And one thing that really hit me was how careful they are about imaging, especially younger kids. Makes sense. They're still growing, so extra radiation, not ideal.
Absolutely. They're all about OLRR. As low as reasonably achievable when it comes to radiation, like simple X-ray, that's often enough for a foreign object or if there's air trapped under the skin, but
Uh,
ultrasound, that's their go-to for masses, tumors, infections, CT scans, only when absolutely necessary.
okay, that's good to know. Especially, for those times when you DO need a CT, like, say, a child takes a tumble, gets a head injury. You immediately think long-term effects.
Even then, they recommend using tools like there's the PCARN head injury study. It helps guide those decisions, avoid unnecessary scans. They point out that the most common type of skull fracture,
hmm
linear fracture, it's basically a crack, doesn't actually affect the brain, and it often doesn't even need specific treatment. Just, watchful eye at home with a trusted caregiver.
Okay, that makes me feel a little better about those inevitable bumps and bruises. But head injuries aside, there's a million things that could go wrong. This publication covers it all. Rashes, more serious stuff like DKA.
And that's emergency medicine, right?
Yeah.
You never know what's coming through the door next.
Speaking of DKA, though, there was something interesting, and it seems we might need to rethink how we've been giving fluids.
Oh, yeah, that caught my eye too. It's like the thinking has shifted based on some newer research. Exactly. This PCARN fluid study from 2018 challenged the traditional approach to fluids for DKA. It suggests that slower rehydration might actually be better for neurological outcomes.
Wow, that IS interesting. Shows you how important it is to stay updated, even on stuff we thought we knew. One thing I did find reassuring, though, was the focus on observation, conservative treatment where possible. It's easy to feel like every sniffle is an ER trip, but sometimes, a little home care is enough.
Absolutely. They drive that point home that many conditions just resolve on their own with the right support at home. Take croup, most cases. Humidified air, a single dose of corticosteroids, you're good to go.
Music to a parent's ears. So much better than a stressful ER trip if you don't need it. Okay, so we've talked minimizing radiation, knowing when those scans are necessary, even touched on the evolving research with DKA. But let's get into specifics, because this publication did not shy away from details. The section on GI bleeding, for example. Now, that's something that, as a parent, can really get your attention right.
Oh, absolutely. I mean, you see blood, you worry. But one thing they point out is that most GI bleeds in kids, thankfully, aren't life-threatening. It's about figuring out where it's coming from, how severe it is, so you can treat it right.
Because they did mention some red flags, things that might signal something more serious is up.
Right. For infants, toddlers especially, you don't want to miss things like intussusception, vascular malformations, Meckel's diverticulum. These can present in a bunch of ways too. The obvious, like abdominal pain, bloody stools, but also, changes in mental status, even sepsis in some cases.
Sepsis, okay, yeah.
Yeah.
That's when you definitely want to be heading to the ER, right?
Absolutely. Sepsis, that's life-threatening. Early
Yeah.
recognition, treatment, crucial. They stress that if a kid with GI bleeding is showing signs of hemorrhagic shock, you focus on the ABCs: airway, breathing, circulation, making sure they're getting oxygen, blood flow where it needs to go.
So those critical cases, it's all about speed. But
Mhm.
what about the less severe bleeds? They talked about rehydration, if I'm remembering right.
Yes, they're very clear. Oral rehydration therapy, ORT, that's your primary intervention for mild to moderate dehydration.
So we're talking Pedialyte, those electrolyte solutions designed for rehydration, something parents can have on hand, thankfully.
Exactly. Now, severe diarrhea, IV fluids might be necessary. They say lactated ringers is preferred over normal saline there. But again, ORT first, always. 5e fluids only if you absolutely need them.
Good to know. It's not an automatic IV situation. Now, what about antibiotics for GI bleeding? Anything surprising there?
They're cautious. Antibiotics only if you suspect a bacterial infection, like E. coli. Goes back to that whole not overusing, antibiotic resistance and all. Most diarrhea cases, supportive care, rehydration, that's the ticket.
It's fascinating how it all connects, right? Like simple diarrhea could be something worse, But sometimes it really is just a bug working its way out.
Exactly. And that's why this resource is so good. Gives you the knowledge to ask the right questions, advocate for your kids.
Speaking of advocating, there was another part that really resonated. Electrolyte problems, dehydration. We've touched on it, but they really went in depth.
Crucial area. Kids, they aren't always the best at telling us what's wrong.
Understatement of the year. So, how do you tell if a child's dehydrated? What should parents be looking for?
They highlight some key things. Severe dehydration, the most serious kind, you're looking at potential signs of shock. Altered mental status, rapid heart rate, delayed capillary refill, meaning it takes longer for the color to return to their skin after you press on it, and decreased urine output.
Okay, those are some pretty clear signs that something's wrong.
They are. But you've also got signs of moderate dehydration, which might include sticky mucous membranes, decreased skin turgor so that the skin doesn't spring back quickly after you pinch it, and irritability, and then even mild dehydration, which might not have obvious physical signs, but you can pick it up from the child's history. Haven't been drinking, been vomiting, having diarrhea, all red flags.
So it's like putting the pieces together. Physical signs, what you know about their activity, and once you've figured out how dehydrated they are, what then? Straight to IV fluids.
No. And they're very clear about this. Do not start IV fluids without trying oral rehydration therapy first. If they're vomiting, antiemetics can help too. Stepwise approach. Avoid unnecessary interventions whenever possible.
That's good to hear. Not every situation's a medical drama, thankfully. Now, there was another condition, and I know this one can be nerve-wracking for parents. Jaundice in infants. Seeing your baby's skin turn yellow definitely gets your attention, right?
Oh, for sure. Common cause for concern. But they point out that while most cases are due to something called unconjugated hyperbilirubinemia, which is generally benign.
Okay, hold on. Gotta pause you there. Unconjugated hyperbilirubinemia. Can we break that down a bit?
I got a little jargony there. So, bilirubin. It's a yellow pigment produced when red blood cells broke down. Normally, the liver processes it, removes it from the body. But newborns, especially preemies, their livers aren't always fully up to speed yet. So they get a buildup of bilirubin in their blood, and that's what causes the yellowing of the skin, the eyes.
Okay, that makes sense. So most cases, it's this immature liver thing, but they did say there's a more serious kind, right?
Right. They mentioned conjugated hyperbilirubinemia, or CH for short. This one's less common, but potentially much more serious. It's when there's an actual problem with the liver's ability to process the bilirubin. Could be a sign of other liver diseases going on.
So how do you tell the difference between the benign kind and something like CH?
That's where a specific lab test comes in, checking the direct bilirubin level. If that's elevated, it suggests the liver's struggling, needs more investigation.
Like a warning light on a car dashboard. Got to get that checked out.
Yeah.
Now, speaking of things needing a closer look, abdominal trauma in kids, they dedicated a whole section to this.
Important topic. Kids, they're prone to those blunt injuries, and they might not always show external signs,
So how do you know if something's going on inside? What should we be looking for?
Well, this is where that PCAR network comes in handy again. They have a decision tool specifically for abdominal injuries. Helps identify those kids who are at very low risk, avoid unnecessary tests, scans.
Always a plus, especially
Wow.
for little ones. But what if further evaluation is needed? What then?
They mention the FAST exam-focused assessment with sonography for trauma, basically an ultrasound looking for fluid in the abdomen. Important note, though, FAST exam, it's not perfect. Can't definitively rule out an injury. Shouldn't be the only tool used.
Got it, so not a magic bullet. They also talked about lab tests, things like liver enzymes, right?
Yep. Elevated transaminases, those are liver enzymes. Those can be a good indicator, especially in infants if there's been an internal injury.
It's like a whole medical mystery, putting the pieces together. History, the physical exam, imaging, lab tests.
That's a great way to put it. And speaking of putting pieces together, let's talk about G-tube dislodgement.
Okay, so this is obviously specific to families dealing with feeding tubes, but still super important to be prepared for.
Absolutely, and they're very clear. Replace that tube within 4 hours of dislodgement.
4 hours, that's a pretty tight window.
It is, and they're adamant about this. Don't delay, even for transfers, consults, gathering equipment. It's that crucial.
Wow, okay, so every second counts. What should parents do if this happens?
They recommend placing a Foley catheter or bladder catheter into the stoma, that's the opening, to keep it open until the new G-tube can be placed. It's like temporary plug. And they even say you can deliver nutrients, meds, fluids through it if you need to.
Wow, that's amazing. Talk about a lifeline. Okay, moving on to another condition that I know can be concerning, nephrotic syndrome.
Nephrotic syndrome, or NS for short, it's a kidney disorder. Basically, you see protein in the urine, low blood protein levels, swelling. One thing they really emphasize is watching for complications, especially infections.
Oh, right, because kids with NS, they're more prone to infections in general, aren't they? Why is that?
It's the protein loss. Protein, it's like one of your body's main defenses against infections. So when kids with NS are losing protein in their pee, their immune systems are weaker, more vulnerable.
Makes sense. What kind of infections are we talking about here?
They mentioned several. Peritonitis, that's an infection of the lining of the abdomen, pneumonia, cellulitis, UTIs. And they highlight the risk of spontaneous bacterial peritonitis, which can be really serious.
So it's like you have to be extra cautious, extra vigilant about any signs of infection with these kids.
Absolutely. They recommend that any child with NS who gets a fever, they need a thorough evaluation to rule out a serious bacterial infection. Some kids might even get prophylactic antibiotics, meaning antibiotics to prevent infections, especially during times when they're at higher risk, like during relapses of the NS.
It's all about staying one step ahead.
Mhm.
Now, another thing I know can be alarming for parents. Hematuria, blood in the urine.
Definitely one of those things that sends parents searching for answers, yeah. But the publication does a good job of explaining that it only takes a tiny amount of blood to discolor urine. Often looks way worse than it is.
Okay, so not always time to panic. But how do you know when it is serious? What are the signs? It's more than just, a scary color.
They have a strategy for evaluating it based on how much blood there is. Normal is considered less than 5 red blood cells per high-powered field, or RBCS-HPF. Microscopic hematuria is anything more than that, and microscopic is when you can actually see the blood.
So different levels of concern. What are some of the common causes in kids, though?
They mentioned 2 common types of nephritis inflammation of the kidneys: post-infectious glomerulonephritis, or PIGN, and IgA nephropathy.
Okay, so 2 specific kinds of kidney inflammation that can cause this. What can you do about them, though?
They recommend a consult with a pediatric nephrologist, a kidney specialist, for further evaluation and management. Lab tests, too, probably. CBC, CMP, that's a comprehensive metabolic panel, and various urine tests to really pinpoint what's going on and how to treat it best.
So again, it's about getting the full picture before you jump to conclusions. Now, switching gears completely, ovarian and testicular torsion. These are definitely up there on the scary scale for parents, I'm guessing.
Oh, for sure. These are urgent situations. Torsion means twisting. So in these cases, the ovary or testicle has twisted, cutting off its blood supply. If you don't catch it quickly, treat it quickly, you can end up with tissue damage, which is not good.
So time is of the essence. What should parents be on the lookout for? What are the red flags?
For ovarian torsion, it's classically sudden, severe pain in the pelvic area, often with the pelvic mass they can feel. Nausea, vomiting, common too. Some girls might even have a fever.
And testicular torsion, same idea.
Similar, but the affected side of the scrotum might be swollen, discolored. The testicle itself might be tender, swollen, higher up than usual. They say one of the most telling signs on exam is the absence of the cremasteric reflex.
The what now?
Cremasteric reflex. Don't worry, most people haven't heard of it. It's a normal reflex that makes the testicle rise when the inner thigh is stroked. If that reflex is absent on one side, big red flag for torsion.
Okay, so that's something doctors are specifically checking for. What about imaging? I'm assuming ultrasound comes into play here.
You bet. Ultrasound with Doppler is the way to go for both ovarian and testicular torsion. Doppler lets them actually see the blood flow so they can tell if there's a blockage.
That's wild. Technology is amazing. So if torsion is confirmed, what happens next?
Surgery, usually. Got to untwist the ovary or testicle, restore that blood flow. And again, early diagnosis, treatment are key to prevent permanent damage. That's the name of the game.
This has been so eye-opening already. We've covered a ton, but honestly, we've just scratched the surface of this incredible resource.
Totally agree. So much more to unpack. Let's dive into some more common and some not so common pediatric emergencies when we come back after the break.
Welcome back. We're diving back into the world of pediatric emergency medicine. And before the break, we were talking about those conditions that sound scary, but often aren't as bad as they seem. Like jaundice, usually just the baby's liver catching up, right?
Exactly. And that brings us to another one of those. Dysmenorrhea, or painful periods. So many women experience it, and it can be really tough.
Okay, so now we're talking teenagers. Whole different ball game than a fussy baby.
Right. But same principle applies. Knowledge is power. They make a clear distinction between two types of dysmenorrhea. Primary dysmenorrhea, that's basically painful periods without an underlying medical condition.
So just your run-of-the-mill cramps, the kind we all dread.
Exactly. And importantly, it's a clinical diagnosis, meaning no specific tests needed. It's about the history, the symptoms.
Got it. But then you've got secondary dysmenorrhea, and that's where things get a little more complicated.
Right. Secondary dysmenorrhea, there is an underlying medical condition causing it, so you need a thorough evaluation. They highlight some things you need to rule out right away, emergent conditions like ectopic pregnancy, ovarian torsion. And then there are urgent conditions like endometriosis, pelvic inflammatory disease, PID, uterine fibroids. Those need prompt attention too.
Okay, so bottom line, if a young woman is having really unusual severe period pain, it's not something to ignore. Get it checked out. Now, on a bit of a sensitive note, they also address genital injuries in children. Definitely every parent's nightmare. But I thought they gave some good guidance there.
For sure. They emphasize, number one, take a detailed history. You need to figure out what happened. And of course, rule out abuse. That should always be a top priority. They also point out that penetrating injuries, so injuries that actually break the skin, those can be more serious than they look.
It's about looking deeper, making sure you're not missing anything.
Exactly. And while we're talking about sensitive topics, they also discuss disorders of sexual development, or DSD.
DSD. That's not a term I'm super familiar with.
So DSD refers to a range of conditions where a child's physical sex development doesn't fit the typical definitions of male or female.
Okay, that's really important to understand.
It is. And they stress the importance of a thorough physical exam to start the diagnostic process. That might mean looking at the external genitalia, looking for anything unusual, palpating for testes in males.
So again, careful observation, being really thorough.
Exactly. And depending on what that physical exam shows, you might need blood tests, chromosome analysis to figure out the underlying cause. It's a complex area. Specialized care is key.
And speaking of areas where specialized care is crucial, skin rashes. Seems like every parent's got a story about a mysterious rash.
Oh, I believe it. Rashes, they're practically their own department in the ER. This publication, though, they do a great job of breaking down the different types.
Huh.
From simple irritant reactions to, the more concerning infections.
They even included toxicodendron dermatitis. Now that's getting specific.
Right. For anyone who doesn't speak Latin, that's your poison ivy, oak, and sumac rash. And here's the thing. That rash usually shows up a few days after contact, but it can take up to 2 weeks in some cases.
Oh, wow. So sneaky.
Yeah.
You might not even realize what you got into until way later. What do you do if you DO come into contact, though?
They say wash the area with soap and water ASAP. Gets that oil off, the oil that causes the rash. Simple, but important. Wet compresses, oral antihistamines, calamine lotion, those can all help with the itch. And if it's really bad, topical corticosteroids might be needed.
Good reminder that sometimes those home remedies are all you need. Now, what about impetigo? That one's a classic, right? Those honey-colored crusts.
The worst. But yeah, super common in kids. Impetigo is a bacterial skin infection.
And treatable with antibiotics, thankfully.
Exactly. Antibiotics are key, and they can be given topically or orally. Depends how widespread the infection is.
So treatable, but got to get on those antibiotics to clear it up. They didn't stop at the common ones, though. They even covered some really serious rashes, like Stevens-Johnson syndrome, staphylococcal scalded skin syndrome. Those sound scary.
They are, and they really emphasize knowing the signs that set these apart. We're talking blistering, skin peeling, fever. Definitely call the doctor material.
Not messing around with those. Speaking of rashes with a distinctive look, they had a whole section on erythema multiforme. That's the target rash, right?
Yep, erythema multiforme. It's a hypersensitivity reaction often triggered by infections or medications, and it makes these really unique target-shaped lesions.
Target-shaped, like literally bullseyes on the skin.
Literally. And the way it looks can actually change over time. Often starts as red spots, welts, then a bump of blister forms in the center, boom, bullseye.
Wow, that's something else. So how do you treat something like that?
Depends on the severity. Mild cases might just need supportive care, like antihistamines for the itch. More serious cases, though, might need systemic corticosteroids to tackle that inflammation.
Okay, so it's not always a huge deal, but good to know it can be.
Now, switching gears completely. Diabetic ketoacidosis, or DKA. That's a whole different ballgame, right?
Absolutely. DKA, that's a serious metabolic emergency. Happens in kids with diabetes when their bodies don't have enough insulin to use glucose for energy.
And insulin's job is to
Help the body use glucose, yep.
Yeah.
Without enough insulin, the body starts breaking down fat for fuel instead. And that process, it makes these things called ketones. Ketones are acidic. They build up in the blood, throw off the body's pH balance, and that's what causes acidosis.
Okay, makes sense. So what should parents be on the lookout for? What are the signs of DKA?
They mentioned the classic triad, a hyperglycemia, so high blood sugar, ketosis, that's the ketones in the blood, and urine and acidosis, the buildup of acid in the blood.
Got it. So if a child is experiencing DKA, what's the plan? What do you do?
They break down the management really well. Fluid resuscitation to fix the dehydration, insulin therapy to bring those blood sugar levels down, and electrolyte replacement to correct any imbalances. So pretty complex. And they even mentioned a possible complication, cerebral edema.
Yeah, cerebral edema, that's swelling in the brain. It's rare, thankfully, but it can be fatal.
Oh, wow. And what causes that?
That's the thing, it's not totally clear. They say the traditional thinking was that it was from giving fluids too quickly, but recent research, like that Piocarn fluids study we talked about before, that's challenged this view. Now it seems slower rehydration might actually be worse for neurological outcomes.
Wow. So what we thought we knew might be wrong. It's a little unsettling, honestly.
It just goes to show research is always evolving. For parents, the bottom line is this. If your child has diabetes and shows any signs of DKA, things like excessive thirst, peeing a lot, fruity smelling breath, abdominal pain, nausea, vomiting, any mental status changes, get them to a doctor immediately.
Don't wait. Better safe than sorry.
Mm.
Now, speaking of blood sugar, let's talk about the other end of the spectrum, hypoglycemia. Basically the opposite of DKA, right?
Exactly. Hypoglycemia is when the blood sugar gets too low, specifically below 70 milligrams per deciliter. And again, you got to know the signs and symptoms because they can be all over the place.
Okay, so we're looking out for
Irritability, confusion, sweating, tremors, even seizures in some cases. It's different for everyone.
Good to know it's not always obvious. What causes it in kids, though?
Could be a bunch of things. The most common, especially in younger kids, is ketotic hypoglycemia. Basically happens when they haven't eaten in a while, their body runs out of glucose to use. Then you've got things like inborn errors of metabolism, hormonal deficiencies, even some medications that can cause it.
In treatment, is it a quick fix or does it require more?
Good news is usually it's pretty quick. Got to get that blood sugar back up and fast. Usually a quick source of sugar does the trick juice, glucose tablets. If they can't take anything by mouth, though, they might need IV glucose.
So get that sugar in them one way or another. Now, there was another condition they talked about, and I'll admit, this one I hadn't heard of before, adrenal insufficiency.
Adrenal insufficiency. It's when the adrenal glands, those sit on top of the kidneys, aren't producing enough cortisol.
Cortisol, that's
The stress hormone, yep, helps our bodies deal with stress, physical, emotional, you name it. Regulates blood sugar, blood pressure, even the immune system.
So not having enough of it can really throw things out of whack.
Exactly. And the symptoms, they can be so vague. Fatigue, weakness, belly pain, vomiting, nothing that screams adrenal problem. But here's the thing. Kids with adrenal insufficiency are at risk for something called adrenal crisis. It happens during times of high-stress illness, surgery, that kind of thing, and that's when it can get really dangerous.
So it's like this underlying vulnerability that you might not even know about until something triggers it.
Exactly. That's why catching it early, treating it, is so crucial.
How do you treat it, though?
Main thing is replacing the cortisol that their body is not making. Usually involves medications like hydrocortisone. It's also important for these kids to get stress doses of steroids during times when they're sick or injured, helps them cope, prevents that adrenal crisis.
It's like giving their body that extra boost when it needs it most. Okay, another new one for me. Thyrotoxicosis. Lay it on me.
Thyrotoxicosis basically means there's too much thyroid hormone action going on. Think of it like their body's thermostat is stuck on high. The most common cause is hyperthyroidism, where the thyroid gland itself is making too much thyroid hormone.
Okay, so it's like their body's in overdrive. What does that actually look like, though? What are the symptoms?
Oh, it can be a whole bunch of things because thyroid hormone, it affects practically everything. Rapid heart rate, weight loss, tremors, sweating, heat intolerance, you name it.
Wow, so it really does impact everything.
It does, but the good news is it's treatable.
How so? How do you even know it is a thyroid issue?
Blood tests, they'll check those thyroid hormone levels. If it's hyperthyroidism, treatment might involve meds to block thyroid hormone production. Sometimes they need surgery to remove part or all of the thyroid gland, but that's less common.
So, manageable, but you got to stay on top of it. Now, let's talk about something that's, well, every parent's worst fear.
Yeah.
Pediatric stroke. It's not something you think about happening to kids, but it can.
Absolutely can. Stroke can happen at any age, even babies. Thankfully, it is much less common in kids than adults. The tricky part is that the signs can be subtle, easy to miss.
Okay, so what should we be looking for? Is it the same as in adults?
Similar, yeah. Sudden weakness, numbness, trouble speaking, vision problems, any sudden change in their neurological function, take it seriously.
So trust your gut. If something seems off, get it checked out.
hmm
What causes stroke in kids, though?
Several things. Could be congenital heart defects, blood clotting disorders, even infections.
And treatment? Is it like in adults?
Depends on the type of stroke, but it might involve meds to bring up clots or even surgery to repair blood vessels. The most important thing is, if you suspect stroke, get medical attention immediately.
No time to waste. Now, we have covered a lot of ground, but there's still so much more to talk about.
Absolutely. We've only scratched the surface.
So let's take a quick break, and when we come back, we'll dive into even more conditions every parent should know about. And we're back for our final deep dive into the world of pediatric emergency medicine. We've talked about so many conditions already, from those everyday illnesses to some really serious stuff.
We have, and this publication really doesn't shy away from those tough topics.
Right, like before the break, we were discussing pediatric stroke. Just the thought of it sends chills down my spine.
Absolutely. It's one of those things you never want to think about happening to a child, but it's important to be aware of.
Exactly, because early recognition is key. And speaking of neurological conditions, they also touch on encephalitis. Encephalitis. That's
Yeah.
inflammation of the brain, right?
Yeah, that's it. And like a lot of things we've talked about, it's usually caused by a virus.
So the brain gets irritated, basically. What are the signs, though? How do you even know if it's encephalitis?
Well, that's the tricky part. The symptoms can be really varied.
Oh,
Yeah, you might see fever, headache, confusion, seizures, weakness. It really depends on the individual case.
wow. So it can look like a lot of different things. That must make it tough to diagnose.
It can be. They stress the importance of a thorough neurological exam, lab tests, neuroimaging like an MRI, sometimes even a lumbar puncture.
Lumbar puncture, that's the spinal tap, right?
One and the same. It's how they check the fluid around the brain and spinal cord for signs of infection, inflammation.
Got it.
Yeah.
And if it is encephalitis, what's the treatment?
Depends on the cause, but it can involve antiviral medications, supportive care to manage those symptoms, and close monitoring to make sure things are improving.
Okay, so it's about figuring out what's causing the problem and then targeting that specifically. Now, let's shift gears a bit and talk about pediatric ataxia. One always sounds a little scary, especially for parents of younger kids who are still developing.
Ataxia, it just means a lack of muscle coordination. So it can affect movement, balance, speech, basically anything that requires coordination.
So picture a kid who's suddenly clumsy, stumbling around, having trouble speaking clearly. That's what we're talking about.
Exactly. Good news is the most common type in kids' acute cerebellar ataxia often happens after a viral infection and usually goes away on its own.
Okay, so it's often temporary. That's reassuring. But what about other causes? Are there more serious things that can cause it?
There are. They mention things like posterior fossa tumors. Those are tumors in the back of the brain, and toxins like alcohol or drugs. Always important to rule those out.
It's like detective work, figuring out what's going on. So how do you figure it out? How is ataxia diagnosed?
A good neurological exam is always the first step. And then, depending on the situation, they might recommend neuroimaging, like an MRI, and blood tests.
Right, so it's about putting those pieces together. Now, speaking of piecing things together, they also had a whole section on head trauma.
Head injuries, yeah. Those are a fact of life with kids, and they can be scary for parents.
Tell me about it. It seems like they're constantly bumping their heads on something. And even though you know most of the time it's nothing major, you still worry.
Oh, absolutely. That's why having good guidelines is so important. They talk about the PECARN head injury study, which we've mentioned a couple of times now.
Right, that's the one that helps determine if a child actually needs a head scan after an injury.
Exactly. Helps avoid those unnecessary scans, especially the ones with radiation. But let's say a child does need a scan, and it shows a skull fracture. How worried should parents be then?
Yeah, because a fracture sounds serious, right?
It can be. But they make a point of saying that linear skull fractures, which are like a crack in the bone but don't affect the brain itself, often don't need any special treatment.
Okay, so those aren't usually a huge deal. Phew. But there are other types of skull fractures, right?
Right. They talk about depressed skull fractures, where there's actually a dent in the skull, and basilar skull fractures, which involve the bones at the base of the skull. Those are more serious and might require surgery.
Got it. So it's not a one-size-fits-all situation.
Yeah.
Now, switching gears a bit, I was really interested in the section on medical technology, specifically devices used in kids with neurological conditions.
Yeah, they talk about things like vagal nerve stimulators, which can help control seizures, and baclofen pumps, which are used for spasticity. That's the muscle stiffness.
Those are some pretty sophisticated devices. I imagine managing them in an emergency situation could be tricky.
You're telling me. But the publication actually gives specific instructions for emergency providers on how to handle these devices, including how to deactivate them if you need to.
That's good to know they've thought of that. Okay, let's talk about another common childhood injury, fractures. Specifically, those involving the growth plate. Parents of active kids, this one's for you.
Growth plate fractures, always a concern. The growth plate, or physis, is that area of growing tissue near the end of long bones in kids and teens. And because it's still growing, a fracture there can actually disrupt bone growth, which you obviously don't want.
Yikes, yeah. So how do doctors even approach these types of fractures? They must be different than fractures in adults.
They have a whole system for it. It's called the Salter-Harris classification system. Basically, it categorizes the fractures based on their location and how bad they are.
So it's a way to determine how much the bone's growth might be affected.
Exactly. Helps guide those treatment decisions.
Makes sense. And depending on what type of Salter-Harris fracture it is, what are the treatment options?
Could be anything from immobilization with a cast or a splint, all the way to surgery. Depends on the individual fracture.
Okay, so it really runs the gamut. Now, another super common injury, nursemaid's elbow. I feel like I've heard that one a million times.
Oh yeah, nursemaid's elbow. Or, to use the fancy medical term, radial head subluxation. Happens when the radial head, that's one of the bones in the forearm, partially slips out of its socket at the elbow.
And it's usually from a pulling or jerking motion, right? Like swinging a child by their arms.
Classic scenario. And usually the child will hold their arm at their side, elbow bent a little, palm facing down. They might be in pain, won't use their arm at all.
So pretty obvious something's wrong. But thankfully, usually an easy fix.
Right. Well, yeah, most of the time a doctor can just pop it back into place with a quick maneuver.
It's amazing how they can go from screaming to back to normal in like 5 seconds.
It is pretty impressive. Speaking of things that seem like magic but are really just good medical knowledge, let's talk about overuse injuries.
Right, because kids are resilient, but they're not invincible.
Exactly. We often think they bounce back from anything, but overuse injuries, those are a big deal in kids and teens, especially young athletes.
Because it's not just about the sudden injuries, it's the wear and tear over time.
Exactly. Think Osgood-Schlatter disease, Sever's disease, Little League elbow. Those are all classic overuse injuries.
So it's about recognizing those early warning signs, the aches, pains, tenderness, not just pushing through it.
Couldn't have said it better myself. Rest, ice, compression, elevation, RICE. That's always a good starting point. And of course, physical therapy can be huge for strengthening those muscles, improving flexibility, and preventing those imbalances that lead to overuse injuries in the first place.
Working smarter, not harder. I like it. Okay, one more condition I want to touch on, neonatal fever.
Ah, yes. Fevers in newborns, always a cause for concern.
So we're talking about babies less than a month old. What's the big deal with fever in those tiny humans?
Their immune systems are still so immature, makes them way more vulnerable to serious bacterial infections like sepsis and meningitis.
Okay, so even a low-grade fever is a red flag in a newborn.
Absolutely. They're very clear. Any fever in a neonate, even if they don't look that sick, needs to be checked out by a doctor. No questions asked.
Don't mess around with that. What kind of workup can parents expect if their newborn does have a fever?
They'll probably do a full workup. Blood tests, urine cultures, maybe even a lumbar puncture to rule out meningitis.
So leaving no stone unturned?
Nope. They need to figure out where that fever is coming from and start antibiotics ASAP if they suspect a bacterial infection. Every minute counts with newborns.
Absolutely. Now let's talk about a scenario that I think we've all faced as parents. Fever without a source. You know, your kid's got a fever, but you have no idea why. It's the worst.
Oh, it's so common, especially in the under 3 crowd. They define fever without a source, or FWS, as a fever lasting less than 7 days with no obvious cause after a history and physical exam.
So you've checked them over and you're stumped. What then?
It's about finding that balance between ruling out serious stuff and not going overboard with tests. The approach really depends on the child's age, vaccination status, how sick they look overall.
So you're using all those clues to guide you. Now, before we wrap things up, I want to mention a few other things that stood out to me.
Go for it.
Tumor lysis syndrome, TLS. It's a serious complication of cancer treatment that I think all parents should know about.
Definitely important. TLS happens when cancer cells are destroyed too quickly and they release their contents into the bloodstream, which can cause all sorts of problems. Electrolyte imbalances, kidney damage.
So a metabolic emergency. What should parents be looking for?
Things like nausea, vomiting, muscle cramps, weakness, even seizures. And it can go downhill fast, so early recognition is key.
And if it happens, what's the treatment?
Aggressive fluids to flush out those toxins, medications to lower uric acid levels, close monitoring of their electrolytes. It's a whole team effort to get things back on track.
Wow, that's intense. Okay, on a lighter note, I also found the sections on breath-holding spells and constipation super helpful.
Yeah.
It's amazing how those two things can cause so much stress for parents, even though they're usually not a big deal.
Oh, for sure. I've reassured countless parents about breath-holding spells. As dramatic as they look, they're usually harmless.
They're scary, though. Your kid turns blue, passes out. It's terrifying the first time you see it.
Definitely. But they almost always outgrow it. Most important thing is to keep them safe during a spell, lay them down, move any obstacles, and just ride it out.
And constipation. It seems like every kid deals with that at some point.
It's so common. My advice, focus on the basics. More fiber, plenty of fluids, and a regular toilet routine. Sometimes a little medication can help, but those lifestyle changes are key.
It all comes back to the basics, right? And speaking of basics, I think the biggest takeaway from this entire deep dive is the importance of knowledge.
100%. This publication is a goldmine of information, and while we've covered a lot, we've only scratched the surface.
Exactly. It's about empowering parents to ask questions, be their child's advocate, and navigate those sometimes scary situations with a little more confidence.
Remember, you know your child best. Trust your gut. If something doesn't feel right, don't hesitate to get help.
Perfectly said. And to our listeners, we'll leave you with this.
Yeah.
What's one question this deep dive starts for you? Something you want to learn more about, discuss with your pediatrician? Hold on to that curiosity, because that's how we become the best advocates for our little ones. Until next time.